wait, we're not really done with how much really is going on in the field. So we have to talk absolutely about checkpoint inhibitors. So what's the story with nivolumab?
So immunotherapy is certainly the theme of the day in oncology and medical oncology in particular across tumor types. And liver cancer is no exception, as you well know. Nivolumab is a PD-1 inhibitor, monoclonal antibody that helps your innate immune system and your lymphocytes to remove an inhibitory stimulus from stroma or tumor and allow immune recognition of a cancer and sort of the immune system to fight the cancer upon relief of that inhibition. So PD-1 inhibitors are now labeled in at least 7 different cancers, including from Hodgkin's lymphoma to kidney cancer, lung cancer, small cell lung cancer. The list is growing by the day. Originally, liver cancer lagged behind given concern about immune toxicity and the risk of hepatitis or autoimmune hepatitis arising in patients that already have a compromised liver function. The first study in HCC was with nivolumab, called the Checkmate 40 study, and did a very careful job at separating out the causes of liver cancer into 3 different buckets of non-viral, so patients without viral hepatitis, patients with hepatitis B infection, and patients with hepatitis C infection, so that each subgroup could be very carefully evaluated for potential immune response, not only immune response against the tumor, but also potential immune toxicity that would be a big problem in this compromised or hepatic dysfunction population at baseline. And the Checkmate 40 study has now been presented several times over the past 2 years and has accrued upwards of 250 patients in its expansion cohort. And it showed a really provocative response rate of about 15% overall across these 3 subgroups, perhaps numerically higher in the non-viral group, but not yet significantly different between these 3 cohorts of non-viral Hep B and Hep C. And so that's a very high response rate by RECIST in the liver cancer population. And not only is the response rate high, but it's been a durable response with a pretty long median duration to date. So that's prompted a large randomized phase 3 trial, Checkmate 459, to follow up on that non-randomized or single-arm phase 2 experience.
And other than nivolumab versus sorafenib, which is the Checkmate 459 in first-line setting, it appears to be that also there's interest in pembrolizumab in second-line setting. So you can tell us about that as well.
Right. So the nivolumab experience has led to other PD-1 inhibitors and PD-L1 inhibitors being explored in liver cancer, including pembrolizumab in a randomized study compared to placebo in second-line, as well as a single-arm study. Those are the the Keynote 240 and Keynote 224 studies that are also accruing very quickly and expected to report in the near future. And some immunotherapy combinations, just like we've seen reach approval in lung cancer and melanoma, the combination of a PD-1 or PD-L1 inhibitor with another type of checkpoint inhibitor called CTLA-4, an older family of drugs that have been approved for a while now in melanoma and prostate cancer. The combination of checkpoint inhibition by PD-1 or PD-L1 and CTLA-4 is now being studied in liver cancer with various combinations of drugs, and we're very excited to see how the results will play out.
Absolutely. Actually, what Katie is referring to is durvalumab plus tremelimumab versus durvalumab versus tremelimumab, which is, CTLA-4 plus PD-L1 versus PD-1 versus CTLA-4 versus PD-1, which is kind of, as you can see, this field is mushrooming quite a bit and really becoming quite extensive, enough that probably will not give fair justice for the number of trials that are going in that field. My understanding, I can't really speak those kind of, words the same way. For me, my very simple understanding of immunotherapy is the T cells are like cars in New York City, and the checkpoint inhibitors are the light signals. And one day in New York, while the cars are on the street, we're going to remove all those light signals. What does that mean from the hepatology standpoint? There's a lot of concerns there.
So I use a similar analogy, except I use brakes as opposed to the lights.
There you go.
Brakes on the car.
We have no brakes in New York.
So the concern has been with hepatitis C and hepatitis B. With hepatitis C, there's not seemed to be a big concern in terms of what has been found in using these immune checkpoint inhibitors. However, Hep B, they've all been, for the most part, at least with Nivo, in Hep B patients who are on medicines, antivirals, with a viral load less than 100. So there's still concern if you cannot drive that viral load down, if you are stimulating the immune system, and Hep B is known for causing problems by stimulation of the immune system and causing this fighting between the immune system and the virus. So that remains to be seen. And I've tried to send several patients with Hep B who are on medications who should have negative viral loads who are still positive, and there may be some interaction with the virus that it is able to hide within the tumor, and you can't get those patients' viral load down, and therefore they've not been able to participate in these trials. In terms of autoimmune hepatitis, you wouldn't expect that someone who's underlying liver disease from other causes should be at a higher risk necessarily of developing autoimmune hepatitis from an immune checkpoint inhibitor. Perhaps in hepatitis C, there is some slight overlap. You could have positive ANAs, and you can see signs of autoimmune hepatitis that is being driven by the hepatitis C. So will that increase the risk? I think that remains to be seen.
If anything, what we're trying to allude to here, that this is a kind of, no doubt, a highly promising field, and especially as we just heard in many indications already has proven its effect. But in HCC specifically, and similar to others, this is not necessarily as simple as we might think it is. This is really a unleashing of the immune system, and really not necessarily with control. The checkpoint inhibitors, the name really means a lot over here. With this said, it's important to kind of, no doubt, try to wait until those trials and contribute to those trials, if anything. And patients, we know very well, are eager to kind of, contribute and be part of those studies. I would resist kind of using those drugs out of a clinical trial. If you're really squeezed, however, just make sure you know what you're doing, because no question that transaminitis, pneumonitis with the nivolumab, etc., are things that really has to be understood and taken care of, and avoiding any complications.